Hello everyone, my name's Steve Lewis and today we're going to be talking about Pennsaid, the NSAID, and ways that I think it can be improved. Pennsaid is a local analgesic and a topical NSAID for osteoarthritis of the knee. And an NSAID, just in case you didn't know, is a non-steroidal anti-inflammatory drug. So before we jump too far into giving you the background on Pennsaid and its mechanisms of action, I want to tell you right up front what my hypothesis is, and it is, would a topical drug that combines the pain-reducing qualities of Pennsaid and the downregulation of COX-2 enzymes via inhibition of the interleukin-1 signal pathway provide pain relief while simultaneously decelerating progression of osteoarthritis? Wow, that is a lot. So we're going to jump right in, give you a little bit of background, and then we're going to come back to my hypothesis to give you more details about it. And hopefully it'll make a little bit more sense at that time. So starting at a high level, we have osteoarthritis, osteo for bone, arthro for joint, and itis for inflammation. And it is a deterioration of cartilage in the knee. And cartilage, just so you know, is an extracellular tissue secreted by specialized cells called chondrocytes. So it's actually outside of the cell. And it's composed of collagen, proteoglycans, and elastin. And you can see right here, this is the knee joint, and you can see that the cartilage is pretty worn right there. So under normal cell conditions, the cartilage extracellular matrix has a remodeling process that basically maintains a relatively consistent volume of cartilage. So this is a homeostatic process that's regulated by metalloproteinases, or MPPs, and these are collagenases, stromolysins, and gelatinases. And MPP activation and synthesis are regulated at many levels. Remember, that is in normal cell conditions. Well, that's a lot of technical jargon, and basically you can kind of think under normal cell conditions, your knee, when you're, let's say, running or biking, or you have any kind of impact that would deteriorate the cartilage in your knee, anything that would cause the cartilage to break down, your body would know, okay, I need to make some more. So those are normal cell conditions. But under pathogenic cell conditions, or in patients with osteoarthritis, there are matrix degrading enzymes that are overexpressed. And again, those are the MPPs that I mentioned on the previous slide. And this would cause an increased rate of degradation, which would ultimately result in a net loss of the things that make up cartilage. So in summary, you've got cartilage, which basically acts as a shock absorber. It's constantly being degraded and remodeled within various joints. And in patients with osteoarthritis, there's too many of the proteins that break it down, and not enough of the proteins that build it up to offset that. So further details, Johns Hopkins researchers have found that patients with OA, like I was saying, have an overexpression of matrix degrading enzymes. You can see in this photo here, we've got same kind of cartoon illustration. Here you've got the cartilage degradation products. One of the ones that I want to point out right now, you might remember it from my hypothesis, is the cytokine interleukin-1. And that is actually found to induce the synthesis of MPPs by chondrocytes and synovial cells, which would cause inflammation and further breakdown of the cartilage. So keep that in mind for the future. So bringing this all back to Pennsaid, it's important to note that Pennsaid literally does nothing to treat osteoarthritis. And you know what? That's okay, because pain management is an important part of medicine. But I like the possibility that you can also treat the disease in addition to treating the symptoms. So we're going to talk more about that with my hypothesis later on. So now that you know a bit of the how osteoarthritic pain happens, we're going to jump into the pathophysiology of the osteoarthritis-related pain. And so specifically, you have this pathway here called the arachidonic acid cascade. And basically what that means is you have a molecule here that's embedded in the cell membrane. And ultimately it gets converted into the things that cause pain and fever and inflammation. Specifically, arachidonic acid is converted into prostaglandin H2, which is the precursor for all of these lovely prostaglandins and prostacyclin and thromboxane A2 as well. But before any of that can happen, arachidonic acid has to go through the COX-1 and COX-2 isoenzymes. And this is how NSAIDs work. This is how Pennsaid, this is where Pennsaid binds. It binds to the COX-1 or COX-2 enzyme, and it prevents arachidonic acid from ever coming down and creating any of these things, including pain, fever, and inflammation. So Pennsaid is said to be an effective COX inhibitor. So we'll jump into a little bit more about COX. So this is what COX looks like. It is cyclooxygenase 1 and 2, and you can basically see that they look really similar. In fact, they are 65% similar. And that's significant enough to allow for selective inhibition. And what that means is drug designers, drug companies, drug development specialists, or what have you, can choose which one of these enzymes they want to inhibit, which can be very useful for drug design. And we'll go into the details on that on the next slide. Keep in mind, COX-2 happens to have a binding site larger than COX-1. So here that is illustrated. COX-2, and here's the binding site, this empty space in here. COX-2 has a larger binding site than COX-1, which is a smaller binding site. And that's due to various amino acid residue substitutions. You can see this isoleucine here is much larger than the valine residue here. And there's other substitutions, but you can take a look at that on whenever you want to. I won't bore you with the details behind that. And basically, drug designers know this, and they know that they can keep arachidonic acid from binding to COX-1 or COX-2 by designing drugs that fit in these binding site spaces. What's more is that they know if they make a drug too large to fit into COX-1, it will fit into COX-2, which will increase the specificity of the drug. And we'll get into why that's important in a couple of slides. So here's the structure of Pennsaid. This is what it looks like. You'll remember arachidonic acid is what it inhibits. So this is what Pennsaid looks like, and this is what arachidonic acid looks like. And they're both competing with each other to fit into COX-1 or COX-2. It should be noted that Pennsaid does a better job. It has what's called a greater affinity for the binding site. Arachidonic acid is usually converted into PGH2 by those COX enzymes, but this process is inhibited because the Pennsaid jumps into the binding site right here and prevents prostaglandin H2 from ever being created. So you'll remember from this slide, this is arachidonic acid. Pennsaid jumps in right here and basically prevents prostaglandin H2 from ever being created. In the presence of NSAID, I should say, because it doesn't last forever. So that's really great. That's great for pain management, but unfortunately there are some side effects of COX inhibitors. And that is the specific class of NSAID that Pennsaid happens to fall into. So like I was saying, Pennsaid is the precursor for PGE2, which happens to be responsible for increasing gastric mucus secretion and decreasing gastric acid secretion in humans, in the normal human. So going back to this slide right here, you can see, PGE2 right here is usually created when arachidonic acid is allowed to be converted into prostaglandin H2, but it's not in this case. So what happens as a result? Well, there are some side effects. Basically, you're at a greater risk for gastric disturbances, having stomach issues, having stomach ulcers, or a larger amount of gastric acid, stomach acid, than your body is used to. And this can be a pretty damaging thing. Um, it's important to note, however, that because Pennsaid is a topical drug, the effects of the PGE2 inhibition is not like as bad as if you were to take, let's say, an oral NSAID. Um, but let's talk about why that happens. So COX-1, you'll remember COX-1, which has the smaller binding site, normally helps to set baseline prostaglandin levels, while COX-2 produces prostaglandins in response to a stimulus. So a decrease in COX-1 is associated with gastric disturbances, and COX-2 inhibitors cause less gastric disturbance. So drug designers are specifically looking to target those COX-2 inhibitors because or specifically trying to find those a drug that will bind the COX-2 enzymes. And the reason they would want to do that is because there would be less stomach issues associated with that. And with other Pennsaids. Thinking about it from a marketing perspective, it would be great to market a drug that doesn't have the side effects that your competitors does, and that's exactly how COX-2 inhibitors came to be. So, with all of that said, is Pennsaid COX selective? Will Pennsaid bind better to COX-2 than COX-1? And the answer is no, not by design, but it does display a minor preference for COX-2. So it is one of the more tolerable NSAIDs in terms of gastric disturbances. Notable COX-2 selective drugs would be Bextra and Vioxx. You've probably heard of Vioxx, and that happens to be 300 times more selective for COX-2 than for COX-1. So you would see that the rofecoxib, the Vioxx, would bind better to COX-2 because it fits into the larger binding site on COX-2 than on COX-1. And that's exactly the mechanism of action of Vioxx. So let's talk about this now that you've got a pretty solid background on osteoarthritis and NSAIDs in general. One of the biggest drawbacks, even bigger than the stomach issues, is that NSAIDs actually cause the acceleration of deterioration of cartilage in osteoarthritis patients. NSAIDs do this by inhibiting chondrocyte proliferation, inhibiting collagen synthesis and proteoglycan synthesis. As you know, that makes up the extracellular matrix of the cartilage. So this is an issue, and Pennsaid is not immune to that issue. It's a part of the problem. So COX inhibitors are widely used to relieve the pain associated with osteoarthritis, but they might ultimately be making the condition worse. So I don't really like that as a concept, but I get it. We may not have had the technology to come up with a way to stop that from happening, and NSAIDs have been kind of the gold standard of pain management in osteoarthritis for so long. But I think that there are possibilities for fixing that gigantic side effect. You don't want a drug making a condition worse ever, and this is exactly what Pennsaid does, unfortunately. So earlier on slide 4, I mentioned those Johns Hopkins researchers, that they mentioned that interleukin-1 has been found to upregulate synthesis of cartilage degradation products, or MPPs. So specifically, interleukin-1 alpha has been found to cause the inflammatory response in the absence of infection, and that's exactly like osteoarthritis. So that's pretty interesting. Let's talk a bit more about that. So this might be crazy, but I actually think it's just crazy enough to work. On this slide and the next slide, I'm going to give you a bunch of facts, and then I'm going to tell you about a drug design that I've come up with that will hopefully improve upon NSAIDs and Pennsaid specifically, and at the very least, hopefully stop them from furthering the progression of osteoarthritis like they currently do. So, interleukin 1 alpha is only dependent on interleukin 1 receptor to trigger inflammatory response in the absence of infection. An interleukin 1 receptor accessory protein, or IL-1RAP, which is now my wrapping name, is a transmembrane protein that is required for interleukin 1 signal transduction via interleukin 1 receptor. Wow, that's a lot of words. So basically, think of this as the messaging pathway. If you live in Virginia and you want to call your friend in California, but President Obama decides to turn off the power in the United States, that call is not going to go through. And that's basically what these two facts are stating. Interestingly, it's already been found that interleukin 1 receptor antagonists downregulate COX-2 protein expression, so keep that in mind. And we also know that COX-1 and COX-2 are found in synovial tissues of joints, so there would be my target in terms of anatomy for my drug. So back to my hypothesis. Would a topical drug that combines the pain-reducing qualities of Pennsaid and the downregulation of COX-2 enzymes via inhibition of the interleukin-1 signal pathway provide pain relief while simultaneously decelerating progression of osteoarthritis? And my theory is yes, since interleukin-1 receptor antagonists successfully downregulate COX-2 protein expression, and interleukin-1 are protein antagonist combined with a COX inhibitor like Pennsaid may be useful as a new kind of combination topical drug to treat osteoarthritis. So here's my theoretical mechanism of action. The interleukin-1 receptor antagonist portion of the drug would result in the following. Production of less COX-2 proteins and less interleukin-1, which would result in less MPPs, or those cartilage degradation products. So obviously less MPPs is great for stopping the progression of osteoarthritis because less degradation would result. And in terms of production of less COX-2 proteins, this could potentially allow for a smaller dosage of the NSAID without resulting in a loss of pain release, at least in theory. And this decreased NSAID dosage would slow down osteoarthritis progression that's currently caused by NSAIDs. Remember, that's a major issue with NSAIDs in terms of treating osteoarthritis. It only treats the pain, but it actually makes the condition worse. So, in summary, my goal with this drug design is to simultaneously relieve pain and slow down the progression of osteoarthritis that are caused by current NSAIDs, like Pennsaid. I want to create a drug that combines the therapeutic and inhibitory effects of both interleukin-1 receptor antagonists and also COX inhibitors. So this goal would potentially be achieved by downregulating the expression of COX-2 through blocking the signal transmission pathway of interleukin-1 and inhibiting the production of interleukin-1 by targeting interleukin-1 receptor or IL-RAP in synovial tissues. Those 2 points, are specifically dealing with the messaging pathway and blocking that. And then 3, reducing the dosage level of the NSAID as a result of 1 and 2. If somebody were to propose this drug design to me, my first question would be, do you think that the lesser expression of COX-2 could have the potential to increase gastrointestinal problems in patients? Because obviously the Pennsaid or the NSAID, Pennsaid in this case, would probably bind more to COX-1 just because of more availability. And my answer is probably. I do think that COX-1 inhibition would happen more as a result of less expression of COX-2. But my hope is that due to points 1 and 2, less of the NSAID portion of the drug would need to be administered. And so ultimately, hopefully that would offset the stomach-related problems. Also, it's important to note that I'm talking about a topical drug, and so there's less bioavailability that you would have to worry about when compared to an oral administration. And I think that it remains to be seen. But yes, I do think right off the bat that that can be something to worry about, but we'll have to find out through research, I would say. Overall, I think it's a really interesting time to be looking into improving NSAIDs, in particular with osteoarthritis. It's my belief that drugs should never make the condition that they aim to treat worse. And that's exactly what Pennsaid and other NSAIDs do in terms of osteoarthritis. So given what we know and what we're constantly learning about different signal transduction pathways, I think it would be cool to design a drug that takes advantage of that, and in hopes that it ultimately prevents osteoarthritis from getting worse as a result, and is currently the case with NSAIDs. So once again, I'm Steve Lewis. Thanks for listening. I hope this has been fascinating for you. Thanks.